thank you for coming. I was a little worried, given my topic, that the only one who was going to get to see this presentation was my dog, Alvin, who saw it multiple times last night and didn't think much of it, I have to tell you. And I say that because when we're talking about efficiency, I'm guessing that most of you don't wake up in the morning like this, thinking, I can't wait to get to work today to make UTMB more efficient, right? Not a big primary motivator for people who work in healthcare. Not even for me as the COO, although I have to admit some mornings I do wake up like this. But I'm hoping that in the next 30 minutes or so, I can help connect some dots for you about why efficiency is essential to best care and why efficiency is inextricably linked to providing high quality care to our patients. So you've seen this wheel. This is the fourth time, at least, if you've been to each of the Lunch and Learns, you've seen the Quality and Accountability Study wheel. So this was our most current performance, and we've talked about every portion of the wheel, and now we're going to talk about efficiency, which is 10% of our total score, and it's in the red. So Dr. Sharma talked about mortality, which is in the red, and I'm going to talk about efficiency, which is in the red, and red generally on these things means what? Not good. Okay, awesome. You're going to do some participation with me. I appreciate that. And actually, in efficiency, this is our worst performing or lowest performing aspect of the Quality and Accountability Study. We're 98 out of 102. So as we like to say in administration, lots of opportunity for improvement in this particular domain, right? We can all collectively roll our eyes a little bit, but we've got some room to improve for sure. So this particular domain is made up of 50% appropriate length of stay and 50% appropriate cost. So that's what goes into that overall score. So we'll talk a little bit about appropriate length of stay. We'll talk a little bit about appropriate cost. And then at the end, I want to take a step back and talk a little bit about the financial health of the organization as well. So let's start with appropriate length of stay. So you notice I'm not using the words reducing length of stay, which I know we've been using those words a lot, and I'm going to show you some data that suggest that our appropriate length of stay should be shorter than in what it is right now when you look at the benchmarks. But what we're really targeting with the length of stay work is an appropriate length of stay. Enough time for us to diagnose the patient, treat the patient, and create a successful discharge plan for that patient through the course of their hospital stay without waste or non-value-added things happening for that patient during the stay. So that's what we're targeting. And the appropriate length of stay has impact not just on this domain, but on the other domains within the quality and accountability score. Because no matter how good the view is in Jenny, and it's good, I don't want to be in the hospital, and most of our patients don't want to be in the hospital if they can be at home in their own bed, doing their own routine, recovering, and not being poked and prodded at the wee hours of the morning for vitals and labs, right? So if we don't have an appropriate length of stay and we have waste in the system, we are going to see an impact potentially in our patient experience scores. So it impacts that part of the quality accountability study. If we have an inappropriate length of stay or fail to create a successful discharge plan for that patient, it impacts what Mark talked about last week in terms of readmissions, right? We get bounce backs. And it also impacts the overall outcome for the patient. Some of you may have been to the talk I did a few years ago on functional decline in the hospital. And I told the story, and I'll tell it again briefly, of my 86-year-old grandmother who had a 9-day length of stay. That was an inappropriate length of stay. It should have been 3, based on her condition. She walked into the hospital completely independent. She walked out of the hospital completely dependent. So an inappropriate length of stay had a significant impact on her life and her outcome. And actually, it took a year before she was more independent and could walk with a walker. And we're lucky because we know in older adults, that functional decline increased her mortality, her risk of death, by 50%. So an inappropriate length of stay can impact all sorts of other things. This isn't, and sometimes I think I've heard, probably no one in this room said it, but the only reason they care about length of stay because it's a money thing. And I guess I'm telling you this because it's not a money thing only. It's about best care. And so we'll talk a little bit about money because there is a financial impact to how we do in this area as well. And we're going to talk about why that's important to think about as well. So when you look year over year, we actually have a really good story to tell. What the takeaways from this slide are we improved year over year 0.42 days in our length of stay. That's pretty good improvement year over year. I know it sounds like maybe a small change, but in terms of length of stay, that's a significant improvement year over year. And that improvement actually led to a savings estimated of $2.88 million. So 0.42 days yields $2.88 million more that we have available potentially to spend. And so if you had an extra $2.88 million, what might you do with that? Anyone? This is the participation part. Anyone? No one has, oh, we don't need it. We'll just put that in the bank. What would you do with that? Equipment. Yes, we have a minor equipment list and a non-threshold capital list that's always longer than we have money to spend, right? We might do equipment. We might hire some additional staff. We might give raises. So this has an important role in our overall health of the organization in terms of our financial performance and our ability to reinvest money that was really wasted with an inappropriate length of stay, and to take that and recapture that money and do something that would be of value to the organization. So now the bad news, which you've seen this in every single talk. Everyone took the opportunity to tell you that Deb McGrew is going to talk about the one thing we're not hitting in the first quarter. So in the first quarter, we didn't hit our length of stay target. So you can see our target was 2.93, and we didn't hit it in any of the first 3 months of the year. So we did see some improvement in November, and we've seen some further improvement in December, and we think January is going to stay, and I always say 3 months is a trend. So we're headed in the right direction. And we'll talk a little bit about what's been done to get us there, what we need to continue to do to be able to hit the target by the end of the year. And while we are getting a little bit of a break on the target in Q2, so it's going up, so that might be a question. Why is the target getting easier in the second quarter? They did some seasonal variation for this and when they set the targets for us. So that's what that is, but actually it ratchets down in the third and fourth quarter. So the goal will get tougher, which is a theme I think you heard from each of the presenters thus far. So in November, our care management colleagues started tracking what we call avoidable days. So with length of stay, we're looking at excess days compared to what an appropriate length of stay is benchmarked. And then within that appropriate length of stay, there may be what we call avoidable days. So waste in the system that's causing the patient to be here longer than they would necessarily need to be if our processes worked better. So in November, we had 294 avoidable days. And that number of avoidable days, let's just do some math here, translated into about $153,000 in waste. So again, who has a way to spend $153,000? Safety equipment, more lifting equipment for the units. Absolutely. So we started tracking this to help us target system-wide interventions to help get rid of those avoidable days or the wasted time in the hospital that's non-value added to the patient's care. And what you see here are some broad categories. And what we learned was the two biggest categories were what we call hospital delays and then community delays. So let's break that down a little more. So the top 5 more specific reasons contributing to those avoidable delays are here. So there are delays in imaging. So we order something, and then there's a delay in actually getting the patient that or getting the results back to the providers. There are delays in cardiac procedures areas, and then we had some external delays. So there's been some work already on the imaging delays. Is anybody from the imaging CS&E team that was on that team here? Matthew. So Matthew's team worked on MRI delays. And what they learned was that one of the bigger portions of the delay there was the time from the order to the time of schedule. And so what we're piloting on 8A right now is a visual cue with an epic for the nurse so they can see that something's been ordered, because there was no visual cue before. You had to look for it. It's trying to make that easier to shorten that window. And then there's some more broad work going on throughout radiology to look at cycle times from when the patient's test is ordered to when the test is resulted, to help work on that as a system issue. Additionally, within cardiology and a few other procedure areas, we've been looking at weekend testing to really start to tackle some of the avoidable delays we have, or avoidable days, that we have, because God forbid you have your chest pain on Friday afternoon and come to the hospital and you need an echo. And we know what was happening before we had the weekend access, which is what? You wait. And is that value added? I mean, if you really like the view and Jenny, maybe. But not value added from the patient's point of view. I'm hanging out. And guess what? Del, when patients are hanging out, do they know they're just hanging out? Yeah. And that usually does not make our patients happy to know that. And it's for the lay public who doesn't work in healthcare, they're like, how could you not do this on the weekend? It's a very strange thing. But we're very excited because our cardiology faculty are now providing these services 7 days a week. So we can get rid of that unnecessary wait for the patient to get the diagnostics testing that they need, so we can get on with treatment and then a successful transition back to home or their next venue of care. So in addition, we have some external things contributing to avoidable days, as you can see here. So we are doing a number of things in this area as well. We're working with our utilization review and our managed care colleagues on prior authorizations and going through those processes. And then also, how many of you saw the announcement about Regent Care? And so we've got now an ownership interest in Regent Care. Now, patients still get to choose where they get to go, but certainly if we have a relationship with a facility like that, we can cut down on some of the back and forth because we are part of them and they are part of us, and to smooth out that transition. But we're also working with our care management teams, and through those poker rounds, does everybody know what poker rounds are? Yes, almost everybody. Progression of care rounds, so those morning meetings to coordinate the care of the patient, coordinate the plan for the day, the plan for the stay, and the plan for the way back into the community. So those rounds are helping us to get referrals to external organizations in the queue more quickly. Because you want to ruin a care manager's day? Rex, you want to ruin a care management's day? Here's how you do it. Friday afternoon, 4 o'clock, roll up on your care manager. Do we have anybody from care management in the room? Yeah, I want to send my patient, they're ready to go today, and I want to send them to a SNF, right? Is that going to happen on Friday at 4 o'clock? No. So it means Saturday and Sunday and probably Monday and maybe Tuesday, we'll be able to get that patient where they need to be. So additional days that are completely wasted from the patient's point of view. So in addition to looking at system-wide issues, we're looking at more service-related issues. So where do we have opportunities when we look at the length of stay index? So the length of stay index is kind of like the mortality index, which we talked about. It's an index, so it's observed length of stay over expected length of stay. So it's an O to E ratio. You remember that from Sharma's talk, right? So, and then what we started to do is target areas that have a length of stay index greater than 1, or had a high number of variance days, as you can see here. And we're working with these individual services to look at, are there practice patterns that are contributing to us having a length of stay index higher than 1 in certain areas. So in addition to focusing on those system level problems, we're also looking at service level and what can we do to make each service more effective at managing to an appropriate length of stay. Now, part of this, because it is an O to E ratio, you'll remember from Dr. Sharma's talk, he talked about working on documentation and coding, right? So there's a whole body of work that's being done to improve our documentation and coding. So if we increase our expected, our length of stay index goes down, hopefully less than 1, which will help improve our overall performance. Are you still following me? I'm getting all statistic-y on you. Okay, so we're looking for a length of stay index less than 1. That documentation work will contribute to improving our performance here. So last month, we introduced the replacement for Dr. Sharma's role before he was announced as the CMO, which is Dr. Patrick Ruckneen, who's serving as an associate CMO. And Dr. Ruckneen is working with me on a variety of things, including meeting with these services to make action plans for how we target reducing their length of stay index below 1. So we had our first meeting Monday with Dr. Lindsay Sonstein and Dr. Luthra to talk about end of discharge procedures in colonoscopy. And so we've got an action plan together for how we can do some things better and impact the length of stay index for that particular service. We're doing the same sort of thing with cardiology and CT surgery together, neurosurgery and neurology together, meeting with the trauma service, and then one more group that I'm forgetting, general medicine and general surgery. So if we're going to hit the goal by the end of the year, these are the critical success factors. We've spent a lot of time implementing and trying to hardwire the progression of care rounds, which I talked about earlier, to improve communication and planning for the patient's admission and ensuring that we have a successful discharge plan for that patient. We've also done some work around what we call the long stay review process. So if a patient is in the hospital for greater than 7 days, they get an interprofessional review with faculty, the care management team, and nursing and others, where we come together and say, what can we do for this patient who's been in the hospital over 7 days to help ensure that we're managing that length of stay and removing obstacles and giving the right support to the team to be able to care for that patient efficiently. We've also have 3 physician advisors, Dr. Leah Lowe, Dr. Tom Kimbrough, and Dr. Marilyn Marks, who are serving as physician advisors. So they're doing doc-to-doc conversations about status of the patient and how they're performing against their targeted length of stay, and helping to make sure that there aren't obstacles or system issues that are getting in the way of getting that patient the care that they need while they're in the hospital. We've also, as I talked earlier, that documentation and coding work will help us in this particular domain. And then we're working with some of the services where we're targeting clinical services at looking at, are there ways to better prepare and plan for external referrals to either hospice, SNFs, or LTACs. And then one of the things we talked to the clinical chairs about, and we're working with our care management partners and others, is making sure everybody knows what the appropriate length of stay target is. So if this patient is in for a cabbage, what's our target? And making sure everyone on the team knows that target for what is an appropriate length of stay for that particular admission. So let's talk a little bit about appropriate cost. So the other 50% of this particular domain is appropriate cost. And just like length of stay, cost is important to our patients. The insurance companies are shifting more and more of the burden of the cost of their care to patients directly, away from the employer to the patient. So what we cost is becoming important. It's being published, and it impacts the patient directly. Additionally, it's important to understand, how do we get paid for an inpatient admission generally? How does that work? We send a bill and then they pay us what the bill is? No, how does it work? Costs are negotiated ahead of time, so it's a flat rate, right? So it's a flat rate. So if a patient's coming in for a cabbage and say, let's make up a number for a cabbage, let's say $100. We get $100 for a cabbage. That's low. We're not getting $100 for a cabbage. But say it's $100. So if the patient stays in the hospital for 2 days, we get $100. If they stay in the hospital for 9 days, we get $100. If we use the thing, we have 2 supplies, and this supply costs $10 and this supply costs $200, the insurance still pays us the $100. We're just working against that flat fee, right? So understanding our costs and making sure we're not wasting and having waste in the system that is unnecessary around our cost is important, both to the patient, who's seeing more of that cost come directly to them, as well as the financial health of the organization. Because if we're spending $200 for that supplies instead of 10, that's money we could have spent on lift equipment or something else that we would like to do with that organizationally. So this last year, we implemented the Patient-Centered Resource Optimization Program. I didn't name it. A couple of our fun faculty named it. I said to them, I have to have a name for this thing so we know what we're talking about, and I hate giving names to things. Can you please give me a name that won't make you roll your eyes when we're in year 5 of this? So this is what they came up with. And this program was designed to start to look at clinical practice variation. So if we take a group of faculty, say our CT surgeons, and we look at all the cabbages they did, and we've got Dr. A, B, and C, and we look at, well, what is a cabbage cost when Dr. A does it? What is a cabbage cost when Dr. B does it? And what is a cabbage cost when Dr. C does it? And oh, by the way, let's look at their quality too, because Dr. C was the most expensive, and guess what he's going to say? My quality is better, that's why I'm more expensive. So we tried to integrate some of that data as we looked at this. And so what the program is designed to do is to bring transparency to cost data to our faculty who are driving those expenses. Because most of the time, 99% of the time, the faculty are completely disconnected to how they are impacting the cost of the organization. So we're trying to reconnect them and help us make good choices so that we're providing an appropriate cost of care, and that we're being mindful about doing that. So here are the results from the first year. We were able to identify $7.23 million in savings associated with reducing clinical practice variation. Now, how did we do that? So half of this is that length of stay improvement. And then the other half is things like, if you've got 2 drugs and they both do the same thing, and one is $10 and one is $100, is there any good reason to use the one that is $100? And sometimes the answer is sometimes. But in several cases, it was like, we were doing this because we had always done it that way, and now that you show us the cost difference, I wouldn't choose that $100 drugs because it's not that much better. It's the same. So some of the improvement was that. Some of that improvement was negotiating better contracts for things that we use in the OR. And then some of that was looking at clinical practice variation. So Dr. A uses some particular supply in the OR that Dr. B doesn't use. Dr. A has no different outcomes than Dr. B, but that particular supply costs $600 every time you use it. So where's the value added there? So, and letting the faculty see that data and have good discussions around if you have choices and you know how those choices are impacting the cost of care for that patient, would you make the same choice with that data? So that's been the focus of this work over the last year. And now with Dr. Rakhneen and his new role, he'll be working to continue this work. We had some outside help over the last year, and he'll be working to continue that so that we can improve the awareness of our faculty of what the cost of care is and how they're impacting that on a long-term basis, and that becomes part of how we do business. So with that said, that's what we've been doing to address the other 50% of the quality and accountability study. So I know that when I start talking about money, that half of you have already glazed over and you're thinking, can I get a second cookie? Would it be rude to do that now? But I want to take 2 more slides of your attention to talk a little bit about money. Because I want to sort of set the stage for why this efficiency section is important for us to improve as an organization with respect to our financial health. So let's start with talking about payer mix. So Donna talked about payer mix in her first Best Care presentation, and she pointed out that when we looked at organizations who were performing well on the Vizient Quality and Accountability Study, they had a very different payer mix than what we have. Does everyone know what payer mix is? It's the mix of patients we have that are Medicaid, Medicare, commercial insurance, or uninsured, right? So what percentage of each do we have? And when you take out our prison patients, this is our payer mix, which is important because on the prison patients, we get cost of care, and that's it. So there's no margin, which means there's no extra money to reinvest into the organization, into all those things we'd like to do with the extra money, right? So this is our payer mix. So we are 16% commercial, and we are 54% Medicaid. This is a tough payer mix. This means we have to be better than all 102 academic medical centers in terms of efficiency to be successful and have a really strong financial health as an organization and have the resources we need to invest in the organization. And part of what many organizations are doing is saying, as a goal, they want to be profitable on what Medicare pays. Why? Because Becky, every year when you go to the payers, our 16% of commercial payers, are they like, hey, Becky, I think I'm just going to give you a 10% increase this year. Is that your conversation? Not exactly, right? Because the insurance companies have their own bills to pay or shareholders to pay. They also have customers called employers who, guess what, don't want to pay more for healthcare every year, right? So they're putting the squeeze on us, which means they're trying to march their rates also towards Medicare. So many organizations are saying we need to be profitable on Medicare. So I just did a little exercise for fun to say, well, we only have 16% commercial business. So what's the impact if on that commercial business we only got paid Medicare? And this was the impact. $48 million loss on just that on going from commercial to Medicare rates on 16% of our business. Wow, right? So we are doing things and what we're doing in the League City market and so forth to shift our payer mix because this is not how you would manage your portfolio, right? So we're trying to shift some and have more commercial patients because they pay better and we can see the impact of that. And then the other takeaway on this slide, which is pertinent, particularly if you were at Dr. Callender's town hall and you're following what's happening in the legislative session, which is not a single one of our services here, actually produces a bottom line, a margin, without general revenue. See this? This is like on a financial slide, this is negative. We would want lines going this way, okay? So the lines are going the wrong way. When you think about, and you hear Dr. Callender talking about reducing our general revenue, we need that general revenue because that's what's giving us the funding we need right now for equipment, for the staffing we need, for the merit and market increases we need to do to stay competitive, to retain the best staff, to be able to deliver the best care. So I know it's no fun to talk about money, and I know, thank you very much for humoring me and coming to a talk on efficiency where I was going to talk about money for a little while. But it's vitally important to the success of our organization, and I hope that you can see that it's also vitally important to the overall quality of the care we're providing to patients, because if we don't have enough money for capital equipment, it's much more challenging to provide the best care, right? If you got something that's half broken, it's challenging. So with that, I'll end and see if you have questions. Is anybody still awake? She asked, what is our strategy to have a better portfolio, a better balance to our portfolio? So how do we get more commercial patients to come to UTMB? And so a big part of that strategy is the off-island clinics and the League City campus and the League City Hospital. The payer mix in that market is very good. It's a highly well-insured market, and so that's part of why you've seen us doing that. So if you ever wonder, well, why are we doing that when we don't have something here? That's why, is we're trying to balance that portfolio and pull in more commercial patients so we have the resources we need to reinvest in the organization. And then we're doing some targeted strategies around particular services to try and grow and that sort of thing.
So my question is, those 3% UTMB employees, what do we need to do in order for our employees to utilize UTMB services and therefore have a better revenue?
Yeah. So we've done some things already, and I will resist the urge to guilt trip the whole room about getting their care here. But we've done some things already. We've done an and shop. We've tried to make it easier for employees to get clinic appointments, both primary care and specialty care. We've also had some discussions that have stopped and started about making it financially better to come to us versus other places. That has larger ramifications from a UT system perspective because they are the ones that negotiate for our health insurance benefits. So we've been trying to push to have more of that activity happening. But you raise a good point. It's important to get your care here. And it's important to tell us and give us feedback because you all know how it's supposed to be for the most part, right? When you go in and something's not right and you work here, you know that's not right. And so if it's not right, we need to know it's not right so we can fix it, because if it's happening to you, it's probably happening to someone else. So the more we use our own system, the better that system will be for all of us and for all the patients we serve. Donna, did you want to say something? Or?
And then I'll give it back. I promise, Kathleen. Some people, Maribel, have been asking, why are we doing the MD Anderson initiative? Mm-hmm. This is another great reason. They're building their outpatient cancer center on our campus to do outpatient work. But if that patient needs to go to the emergency room, urgent care, be hospitalized, that's all going to happen in our facilities. So the benefit to us, because they have they have a lot of commercially insured patients, they will come to us as they need additional services. So that's another important, some people say, why are we doing certain things? Just stop and ask yourself, is that going to help increase that commercially insured base that Deb was talking about. And oftentimes you're going to hear the answer to that is yes. And so this is just when people say, why are we doing this, MD Anderson? That's one of the reasons why, in addition to wanting to be collaborative with a sister UT system organization. So I grabbed the mic from Kathleen, so I'll give it back to her now.
Actually, I'm speaking on behalf of HR leadership, who actually is at a benefits conference today. And I can tell you that Dr. Ron McKinley and our benefits director, Tony Edmond, is working diligently on this particular challenge. And so stay tuned. I have a lot of faith in Dr. McKinley when he wants to go forth and do something. And so we are indeed, from a human resource benefit perspective, working on that very issue. And I also received my care here, and I had awesome care, and I tell everybody about it. And maybe that's what we need to do, is to start to be just an advertiser of the care that we get here.
So when we talk about best care, we usually think about preventive care. And so how are we helping with that throughput with more maybe preventive care on the outside, more clinics on the outside, and get away more from freestanding hospital, making more rooms, you know?
Yep.
I would think that would probably be I didn't hear you mention anything on it.
Yep, I didn't. And so the quality and accountability study is very inpatient focused, which is why that was the focus of the talk today. But your broader question is a good one, because so I spent 8 years working with psychiatry before I came here. And in psychiatry, every inpatient admission is considered a failure. It's a failure. We failed to manage that patient in the community. And I often think about that when I look at the other parts of our operations, and it's kind of the same thing, right? It's a failure, potentially. I mean, you know, if you get in an accident, okay, well, maybe it was a failure to not be texting and driving, or whatever, right? But if you look at it that way, and we are doing some things, and I'll tell you what specifically around prevention. So last year, Anne and the ambulatory team started a program that they called Gaps in Care. So we were looking at all the patients that are in our primary care network that are our patients and assigned to us. And we basically started getting more proactive at saying, it's time for your mammogram, or it's time for your colonoscopy, or it's time for this preventative thing, and reaching out to them directly and saying, we'd be happy to schedule that for you. How do we make that easy for patients? And so that work started last year or the year before. So we've been doing that for a little while now. And then also, Becky Krenik has been working and partnering with our payers to begin to be incentivized to actually do what you're talking about. Because right now, we get paid for sickness, right? We don't get paid for wellness. That's the way the market works. You get paid for sickness. So she's been working on what we're calling value-based contracts, which is, and we have one with Blue Cross and we have 2 others coming on board, where they're saying, okay, we're going to actually pay you to case manage a group of patients. Because right now, if we case manage the patients, we get nothing. And so they're going to pay us for that. And then they're going to say, and then we're going to bonus you if you can lower the cost of that population's care and meet these quality indicators. A lot of them around preventive health issues, and then some of them are more outcome issues. So we're starting to get into that space and are doing a lot of testing new ideas and working with our primary care groups on how do we more proactively manage a population of patients across our system.
I noticed your data since 14, 15, and I know we've done a lot of growth.
Yeah.
Are those numbers starting to change? Are you starting to see an impact?
Little bit. The payer mix has improved a little bit, but it's not a dramatic change. Yeah. Yes. The question was, the data was 14, 15. and it wasn't fiscal year because we kind of did it in the middle of the year. And is that data still about right? And the answer to that is yeah, that data is about right. We have seen some improvement in our payer mix. Certainly opening League City Hospital is going to help us improve our payer mix overall. But that $48 million isn't getting that much better based on the shifts we've seen thus far.
Mention anything about readmission, and once you got paid for that admission, chances are we're not going to get paid again for that readmission, and I didn't see that in your equations.
Right. Now, Mark talked about that last time, talked about readmission rates, and there is a lot of work going on around making sure that the discharge plan we're making will be successful for that patient so that they can transition outside of the hospital and successfully execute the plan that we've worked with them to develop. Mark?
You had a really good slide that talked about the changes from 15 to 16, as well as the stacked bars that talked about avoidable days. Do you think there was any, and I suspect you've already done this work, was there any influence on that about our usage of observation days?
Yeah.
Because they change also while you're doing this.
Yes. And Mark raises an important point. So this is going to get really kind of geeky for a minute. So absolutely. So we, over the last year, have gotten better at statusing our patients. So you can be admitted as an inpatient, or you can be in the house and you're not really admitted, you're in this observation status. And we, on the whole, had too many people who were admitted as inpatients that didn't meet what's called inpatient criteria, which means you don't meet enough, you're not sick enough to be considered an inpatient, and you really should be an observation patient. And this is where appropriate cost and appropriate length of stay really matters from the patient point of view, because if you're a Medicare patient and you're an observation patient, the amount of, you have a much stronger tie to what you're going to get charged for based on how long we keep you in that op status. So we have seen some shift of patients that were probably not in the correct status, and we've gotten better at that, and that has helped our length of stay, has changed our length of stay picture. The other thing that's really helped is because of some of the coding and documentation work, as our case mix index goes up, so as our patients are actually reflecting how sick they are, our expected is going up, and our performance in this metric is going up as well. So we're doing better as a result of more accurately reflecting how sick our patients are. Anything else? There's one over here. Jason?
No.
Which prop slide? Oh, the 7.3 million?
I just wonder if that, is that going, is that limited only to those areas of focus, or is that data available all across the hospital? And if
Yeah, so these are the areas we started with and targeted. We had a year, this was a margin improvement initiative to help us hit the budget. And we had a $5 million target, and there were lots of opportunities. This is how we narrowed the field to make sure that we could actually execute on the 5 million target. But what I mentioned about Dr. Rakneen is that we will be, this is work we should be doing all the time. And we want an organization where our faculty see their cost and their impact on the organization all the time. And so through the strategic plan, one of the strategies is to continue this program and develop this program and use our data warehouse that's being developed and leveraging that investment to make sure that we're providing regular feedback to the environment and that we're targeting system-wide initiatives to reduce the total cost of care by reducing practice variation or things that are non-value added, or to do a better job of negotiating how much we're paying for things. So there'll be more than just these areas as we continue that work.
So I'll share a personal story in somewhat vague terms, as I realize it looks like we're being taped. So a few years ago, I needed to have a procedure, and so I asked about 7 or 8 different of our UTMB employees 3 different disciplines. And because I didn't know a lot about that, and so I said, so if you had to have this procedure, which would you choose to have that done? And so of those 7 or 8 and in 3 different disciplines, all but one said, oh, if I had to have that, I would not have that done at UTMB. I would go to so-and-so in Clear Lake or so-and-so in the Houston Medical Center or whatever. So I share that only to say that my feeling is, or my suspicion is, that there are likely trends, that there are some things that our own employees would stay on campus to have based on their observations in terms of how their patients do and and such, versus there are some things, perhaps there are trends in what we have a tendency to leave the campus for. And so my assumption or my hope is that that's one piece of data that's being looked at carefully, because that may very well be low to medium hanging fruit. Does that make sense?
Yes.
Okay.
And you're raising a very good point, Odette, and something that actually Ann and Jeremy are starting to tackle. They went and met, we call that out-migration. So, and where do we have our own providers referring out of our system for services for their patients? And so we ran a big report and we said, where do we have patients leaving the system? And then we aggregated that report by doctor. And then we went and started talking with our CBC docs about, you know, you got a lot of out-migration around, let's just say, I'm going to pick on radiology, MRI services. What's that about? You know, we've got really nice MRIs. What's that about? And so we started talking to them about that for a couple of reasons. One, we want to understand if there are system issues getting in the way. We want to understand if our costs are different than what you pay outside of UTMB for something. And if there's a difference, then we need to look at that. If we're not competitive, we need to look at that. And so we're going through that process now. And then we're also, because that will lead to some of the discussions you're talking about as well, we've got maybe some problems in that area that need to get cleaned up. Many of those kinds of things are actually being addressed through Best Care, because we've got the quality data now, and we can see where we're at, and we can see where we're improving, and we're able to target areas that, you know, maybe that, you know, we know we had some quality issues in that area. Let's look at the data and let's fix it. So that way we can all feel like, you know what, I would come here for that, and not have patients being referred out of the system. Well, awesome. Have a wonderful afternoon. Thank you very much for being here.
UTMB Health, working together to work wonders.